Good evening and welcome. My name is Sherry Singer, and I'm the National Director of Engagement for the Northeast for the American Liver Foundation. Welcome to today's webinar, Ask the Experts, Liver Cancer Symptoms, Diagnosis, and Treatment. The American Liver Foundation is the nation's largest nonprofit serving people with liver disease. Since 1976, we have provided a voice for patients with liver disease and their families through education, support services, research, and advocacy. Throughout the current pandemic, our commitment to liver health education is stronger than ever. To begin our evening, I would like to welcome Isabel Zacharias from UMass Medical Group and Chair of the New England Medical Advisory Council to open our program and presentations. Isabel?
Thank you, Sherry, and welcome everyone. My name is Isabel Zacharias. I'm a gastroenterologist and transplant specialist at UMass Memorial Medical Center, as well as the chair of the New England Medical Advisory Council. Welcome to tonight's webinar. We're all very excited. Liver cancer is a big and broad topic. It can be a little overwhelming. So the ALF is here to educate and support you. If you or someone you love has liver cancer, we really hope you leave this evening's presentation feeling more knowledgeable about topics vitally important to you as a patient or a caregiver.
Good evening. My name is Caroline Johorian. I'm a gastroenterologist at Integrated Gastroenterology Consultants of Lowell and the American Liver Foundation New England Medical Advisory Council Vice Chair. Together with Isabel and Tom Seepy, who we will meet during the question and answer time, we are thrilled to present a robust group of New England medical professionals to share their knowledge of adult and pediatric liver cancer. You will have time at the end of the program to ask questions from our panel of distinguished physicians. We hope you will leave this evening with more knowledge on this challenging subject and feel you have been given a platform to ask your virtually important questions.
So before we get started, I wanted to share a few housekeeping items. This evening's presentation, like all ALF education events, is being taped and will be available on YouTube following the evening. We have muted everyone's microphones except for the speakers. If you'd like to ask a question to our expert speakers, please use the chat feature at the bottom of your screen. To access the chat feature, simply hover your mouse along the bottom of your screen, and in the center along the bottom, you'll see a word bubble, and under it, the word chat. You may ask questions at any time during the webinar, and the speakers will answer questions during the question and answer session after all of the speakers have shared their presentations. There won't be an opportunity to ask questions in between live, but save all of your questions or send your questions right through and we will get to them at the end. Our intention is to answer all questions. Your participation is absolutely welcome, so please don't be shy. We are here to support you.
A huge part of the success of the American Liver Foundation continuing to successfully share our mission to promote education, advocacy, support services, and research for the prevention, treatment, and cure of liver disease, especially during these challenging times, is the support from our national and local sponsors. Thank you to tonight's national sponsors, ASI and Intercept, and our local hospital sponsors, Boston Children's Hospital, Gastroenterology Consultants of Lowell, UMass Medical Memorial Center, and University Gastroenterology in Providence. Now let's get started. Our first speaker this evening is Dr. Newton, gastroenterologist from University Gastroenterology of Providence. He graduated from Dartmouth College and attended University of Vermont Medical School. Dr. Newton is a clinical associate professor of medicine at the Alpert Medical School at Brown University and will speak this evening on liver cancer in adult patients.
philosophical or theological discussion, but we'll try to answer that question as well. And then when it does happen, how do we deal with it as physicians and patients? What are the next steps? And again, that's going to be further addressed in some of the other lectures that you'll be hearing, but I'll briefly sort of allude to some of the things that you'll be hearing more about. So to the first question, what is it? What is liver cancer? It is a tumor that arises in the liver and is what we call a primary tumor of the liver, meaning it starts in the liver, as opposed to other tumors which can start elsewhere and spread to the liver. So it's a primary liver tumor that usually, but not always, but usually develops in people who have long-standing liver disease. And we see it the vast majority of the time in patients who have cirrhosis. So what is cirrhosis? Cirrhosis is a condition where you have long-standing damage that's occurred to the liver, which leads to scar tissue formation. And scar tissue builds slowly over time, and we generally score scarring on the liver on a scale of 0 to 4. And when you have enough scar tissue that we call it, hello everybody, I want to introduce myself first. My name is Eric Newton. One of the physicians at University of Gastroenterology. I'm an associate clinical professor at Brown. And I want to thank everyone at American Liver Foundation who has worked so hard to put together this symposium and webinar, particularly Sherry Stringer and Isabel Zacharias, or Dr. Zacharias. And thank you for inviting me to give this lecture. So we're going to launch right into the discussion, which is liver cancer in adult patients. And we'll have an opportunity at the end of all of these lectures to have an open forum where people can ask questions. And unfortunately, it's not possible during the slide presentation, but will be available in just a brief period of time to answer any questions you might have. So in order to discuss this, I figured I'd break this down into commonly asked questions and the who, what, when, wheres, and whys, all the W's and the how as well. So this is just a brief outline of what I'll be reviewing on liver cancer. Exactly what is it? Who gets it? When does it happen? Where does it happen? Where is it? Why does it happen? Which is perhaps a little bit more of a philosophical or theological discussion, but we'll try to answer that question as well. And then when it does happen, how do we deal with it as physicians and patients? What are the next steps? And again, that's going to be further addressed in some of the other lectures that you'll be hearing, but I'll briefly sort of allude to some of the things that you'll be hearing more about. So to the first question, what is it? What is liver cancer? It is a tumor that arises in the liver and is what we call a primary tumor of the liver, meaning it starts in the liver, as opposed to other tumors which can start elsewhere and spread to the liver. So it's a primary liver tumor that usually, but not always, but usually develops in people who have long-standing liver disease. And we see it the vast majority of the time in patients who have cirrhosis. So what is cirrhosis? Cirrhosis is a condition where you have long-standing damage that's occurred to the liver, which leads to scar tissue formation. And scar tissue builds slowly over time, and we generally score scarring on the liver on a scale of 0 to 4. And when you have enough scar tissue that we call it level 4, that's what cirrhosis is. So you have lots of scar tissue in the liver, and the liver starts to develop nodules in response to all the scarring that's there. And that's what cirrhosis is. The vast majority of the time we see these liver tumors in patients with cirrhosis. The two most common reasons that we see patients with cirrhosis and with liver tumors, at least in the United States, is chronic hepatitis B. Patients with chronic hepatitis B can get liver cancer either with or without cirrhosis, and also chronic hepatitis C. Patients with chronic hepatitis C almost always will have cirrhosis if they develop liver cancer. Nothing is ever 100% of the time, but most often our patients with hepatitis C with tumors or cancers in their liver do have cirrhosis as well. It is the sixth most frequently diagnosed cancer worldwide, so it is common. It is the fourth most leading cause of cancer death worldwide. And so unfortunately, it does not have the best survival. The 5-year survival of any patient with liver cancer is only 18%, making liver cancer the second most lethal tumor after pancreatic cancer. Its incidence is rising, and so we are unfortunately seeing more of this, not just worldwide, but in the United States as well. So we were talking about what the tumor is, and that's sort of a very broad overview of what liver cancer is. But now we'll go on to who gets it. So we mentioned patients with cirrhosis are by far and away the most common group of people who will develop this tumor. For some reason, men are more common to get it are more likely to get it than women. So it's more common in men at a 3-to-1 ratio. And the highest incidence worldwide is actually in Asia. And the reason for that is due to the high incidence of chronic hepatitis B in Asia. And as we talked about, patients with hepatitis B are at risk for developing liver cancer even without cirrhosis, so with or without cirrhosis. And because of the high incidence of hepatitis B in Asia, the highest incidence of these tumors occurs there as well. So I mentioned hepatitis B. Some of the risk factors for people with hepatitis B to get these tumors are if they have a high viral load or a large amount of virus in their bloodstream that increases the risk of getting the tumor. One of the blood tests that we often do in people with hepatitis B is to look at their surface antigen. And it's one of the things that your doctors will test and look at. And patients with high surface antigen levels are also at risk. There is something called hepatitis D, which can kind of go along with hepatitis B at times and make it a little bit more difficult to treat and change the nature of the infection a little bit. And so if you have both infection with hepatitis D and hepatitis B, the risk for developing liver cancer is higher. There's different strains of the virus. We most commonly think of different genotypes and strains when we're talking about hepatitis C, but hepatitis B has different strains as well. And genotype C is a risk factor. The presence of hepatitis B E antigen is a risk factor as well. And again, that's another test that your doctor will be ordering in the face of hepatitis B infection. And then lastly, if there is a strong family history of liver cancer, that will increase the risk of a patient with hepatitis B to develop liver cancer as well. So some of the risk factors that can go along and lead to the development of liver cancer. We mentioned a few of them, like hepatitis B and hepatitis C. I left hepatitis B out of this slide because we just talked about it at some length. But as I mentioned, hepatitis C infection. Aflatoxin is a toxin that's developed by mold and yeast, which can grow on food, and in sufficient quantities can actually be toxic to the liver and predispose people to growing these tumors. Thankfully, that's extremely rare. Iron overload conditions, such as hemochromatosis, which you'll see on the right side of this picture slide. And hemochromatosis is a genetic condition where patients will absorb too much iron from the food that we eat. And the body doesn't know when to turn down the signal to turn off that absorption. So we'll absorb too much iron. And if the iron levels are elevated for extensive and long periods of time, the liver doesn't like that and can start to lead to changes in the liver cells, which can predispose people to getting these tumors, cirrhosis in these tumors as well. I wrote tobacco use and alcohol use, but it's really more abuse than use. But anybody who's smoking or drinking too much, some of the toxicity of those chemicals can, again, predispose to tumor growth. I haven't mentioned fatty liver yet, but NAFLD and NASH are abbreviations for non-alcoholic fatty liver disease or non-alcoholic steatohepatitis. And those are descriptions where fat has infiltrated into the liver and that fat can cause significant inflammation of liver cells. And again, anything that really causes inflammation in those liver cells over long periods of time can lead to scarring and cirrhosis, which can ultimately lead to genetic changes, which again predispose people to growing these liver cancers and tumors. Obesity and diabetes are felt to be risk factors as well, but those tend to go hand in hand with NAFLD and NASH and fatty liver, and that the people, patients and people who are obese with diabetes are more prone or more likely to have fatty liver and more likely to have not just fatty liver, but inflammation and damage from fatty liver, and that's what NASH is. So again, people with obesity and diabetes are more likely to have inflammation from fat or NASH, which can lead to scarring and damage. There are other diseases and conditions which can lead to scarring and damage and cirrhosis and liver tumors. I have not put them all on this slide, but a few examples are alpha-1 antitrypsin deficiency, which is a problem with certain proteins in the liver, which are mutated and fold incorrectly and accumulate in the liver and again lead to inflammation and damage. PCT stands for porphyria cutanea tarda, anabolic steroids, and the list does go on. Thankfully, these are rare and not common at all, but occasionally we do see these as reasons for people to have cirrhosis and damage and ultimately liver cancer. So we're moving on from who gets it to when does it happen. We've reviewed a lot of that, again, in patients with the risk factors that I just reviewed. Any of those risk factors which can lead to scarring and damage and cirrhosis of the liver, again, that's the predominant risk factor is the presence of cirrhosis. We often find these tumors on incidental findings. So sometimes patients will present for other reasons other than known liver disease. So a lot of times we see people who don't know they have liver disease or don't know they have liver issues. And they'll sometimes come into our office or present to the emergency room with other complaints. Sometimes we'll do CAT scans or imaging on these people and at times incidentally find these tumors. So we're not always looking for them when we find them, but sometimes we find them when we're not looking, specifically for that reason. You'll see next on the slide, we often find these in patients on surveillance protocols. So what does that mean? Anytime we see a patient in the office with cirrhosis or someone's diagnosed with cirrhosis, we usually will enroll them in a surveillance protocol, which means that every 6 months in anybody with cirrhosis or anybody with hepatitis B, generally we're doing some blood work and or some imaging of their liver approximately every 6 months. And so what is that surveillance protocol? It's basically we're doing blood work. We're looking for a specific tumor marker, which can be seen in patients with these liver tumors. And we're doing some imaging test, whether it be ultrasound, CAT scan, or MRI. Most commonly, it's an ultrasound to begin with. But sometimes on these surveillance blood tests or imaging tests, we find new growths or find growths of tissue, which ultimately end up being these liver cancers. So that's frequently where we'll find these tumors. The whole purpose of this surveillance protocol is to find these tumors when they're small. And the earlier we find them and the smaller they are when we find them, the more likely we are to be successful in managing and treating it. And so finding them early is important. Doing the surveillance protocols and then having your doctor sort of enroll you in these surveillance protocols is incredibly important for that reason. Again, these are things that will be touched upon in the lectures as we go forward, but that's an important point that I wanted to be sure to make. So I mentioned alpha-fetoprotein. That's a tumor marker that your doctor will be testing you for every 6 months or every 12 months as part of these surveillance protocols. Sometimes when we see the alpha-fetoprotein levels rise, or if they're elevated, it makes us more suspicious that there might be one of these tumors in the liver. Unfortunately, they're only elevated about 40% of the time in small tumors. The larger the tumors, the more frequently the alpha-fetoprotein will be elevated. At times, the levels can be extremely elevated. which again really leads us to believe that these tumors might be in your liver and growing, and leads us to be a little bit more aggressive in the pictures and the ordering of MRIs or CAT scans to try to look for them when those alpha fetoprotein levels are elevated. Again, unfortunately, this tumor marker is not always elevated, even in people who have these tumors. So even if the levels are normal, it doesn't mean that one of these tumors is not growing in your liver. So we combine that liver test with imaging of the liver. And imaging can be ultrasound, MRI, or contrast enhanced CAT scan. Again, most of the time when we're doing this initial screening and the initial surveillance protocol, we'll start with an ultrasound as a place to begin, and then move on to CAT scan or MRI if we start finding something that's a little bit suspicious. So last slide, I believe, on when does it happen? One of the most common questions for people are, in our patients with cirrhosis, they'll tell us, they'll say, okay, we're looking for these tumors. What should I be looking for? What are the signs or symptoms that maybe I am growing liver cancer? That's a very commonly asked question. And there can be a variety of symptoms, but most frighteningly, there can be no symptoms at all. And I'd say most often there's really no symptoms in patients who have these tumors that are growing. Unfortunately, it'd be nice if there was something we could always look for, but oftentimes we're just screening our patients with no symptoms, and that's when we find the tumor. So very frequently people don't have any symptoms or any changes to their symptoms at all. Sometimes people will have fatigue. Sometimes they'll start losing weight unintentionally. That always gets our ears perked up a little bit and raises our level of concern. Sometimes people will say that they're feeling full quickly, or what we call early satiety, meaning you're satiated quicker. So if you're feeling full, quicker than you normally are, and you can't eat as much, or you're feeling nauseous after eating only just a small amount, that sometimes is a concern or a signal. Rarely patients will have these tumors growing on the very outside of the edge of their liver. And these tumors can occasionally sort of rupture through the capsule that surrounds the liver and cause bleeding into the abdominal cavity. That's a frightening event when it occurs, and is sort of a life-threatening situation, and thankfully is not something we see very much at all. But again, can be a presenting sign or symptom that there is a tumor in the liver. And sometimes that happens, and we don't know that these tumors are growing, and patients will present with bleeding into their belly, and that's really the first sign that we have that there's something bad happening in the liver. So again, thankfully that's rare, but it can happen. Rarely these tumors can grow into some of the big veins or vascular structures around the liver, or leading into or out of the liver. And if the tumor grows into these veins or vascular structures and blocks one of them, it can cause changes in the body and the abdominal cavity and in the veins around the area that can cause other issues. It can cause bleeding. It can cause fluid accumulation into the belly. And so sometimes we're seeing patients who are getting these complications that we sometimes see in people with cirrhosis. And the complications are due to these tumors, which have grown into some of the structures around the liver. Again, thankfully, rarely there can be other rare presentations of these tumors, such as low blood sugar levels, high blood calcium levels, skin rashes, diarrhea, and again, that list goes on and on. Thankfully, those are rare and unusual presentations, but can occur as well. So moving on from when to where, these are some schematics or pictures of these tumors. The first is sort of a cartoonish figure, but I think gives you a pretty good idea that if we cut the liver open, you can see the normal sort of purplish, reddish tissue of the tumor, of the liver, excuse me, and then the tumor kind of growing as almost the white sort of circular diagram of the tumor. And then on the right-hand side of your screen, this is an anatomical slice of an actual liver. either a liver or a tissue that's been removed from someone's body. And again, you see the normal sort of reddish, almost purpley red appearance of the healthy liver, and then you see the tumor growing in the upper right-hand corner, which again has a sort of whitish appearance. So these tumors can occur really anywhere in the liver. Sometimes they're more central and sometimes they're more peripheral. On this next slide, you'll see sort of a CAT scan slice of someone with one of these tumors. I'll try to move my mouse so you can so I can highlight the tumor area. But again, you see it as a white area that sort of has become bright with the contrast that's given on the CAT scan that makes that tumor kind of light up so we can see it on the CAT scan. And so where do we see it? I've mentioned some of the modalities, including ultrasound, CAT scan, MRI. Just a few things I wanted to touch upon there. So, when we're doing our surveillance protocol, sometimes on ultrasound, we'll see a new lesion or a lesion that was previously small that has grown in size. And again, that makes us a little concerned that something may be growing. If we're seeing a very small lesion, less than 1 centimeter, sometimes we'll just choose to watch that and see if those little lesions grow. And we'll monitor that every 3 or 6 months. Once those tumors really become bigger than 1 centimeter, oftentimes we're ordering a second line imaging test, such as the CAT scan or MRI, to take better pictures and to better delineate exactly what we're dealing with. Oftentimes we will move on to either a contrast enhanced CAT scan with different phases of the contrast and different phases of the imaging that we take, and the same with MRI. In order to undergo these tests safely, both the CAT scan and the MRI, the more normal the kidney function, the safer the test is. Sometimes the contrast will be or can be toxic to the liver. So if someone has toxic to the kidneys. So sometimes if someone has underlying kidney problems or kidney function abnormalities, we sometimes hesitate a little bit to order these tests. But if there really is a concern that there is a tumor there, there's things that we can do to minimize that risk to your kidneys and make it so it's a safer test. Another question I often get from my patients who are undergoing CAT scans is they're concerned about the radiation exposure that may occur with a CAT scan, and patients often ask, should I be worried about the radiation that I might get from a CAT scan? And if we're really concerned that there's a tumor in the liver, the thought is that radiation exposure is not thought to really be meaningful. And while it is a small amount, it's not a amount that puts really any significant health risk to the patient or to the adult patient in particular. And so we're usually comfortable ordering that CAT scan. As far as MRIs, another question I get from patients are, I'm claustrophobic and I don't want to do an MRI. Again, if you're claustrophobic, an MRI can be a problem. There's medication that we are able to give people to make them a little less anxious and nervous and help that claustrophobia. And another question that often comes from that is, well, if I am a little claustrophobic, can I do an open MRI? Is that okay? Does it have to be one of the closed MRIs if I don't want to get in one of those tubes and lay there for 20, 30 minutes? Ideally, a closed MRI is better than open. I think an open MRI is better than nothing. But if it's closed, that's sort of the standard. And we do know we get really more ideal pictures in that scenario. So if you can figure out a way, even if you are a little claustrophobic, to get in the closed MRI, that does help. So moving on, the next question is, well, we found one of these tumors and we're pretty sure it's a liver cancer. Do I need a biopsy? Do we need to biopsy it? And I put that cute little picture of a duck to remind me to talk about that. Oftentimes we say with these tumors, if it looks like a duck and it has and it quacks like a duck, then most likely it is a duck, and the same with these tumors. So if it looks like a liver cancer and it's got the classic imaging features of a liver cancer in a patient that we think is at risk for developing liver cancer, we're usually comfortable saying that, yes, this is a liver cancer, and no, we don't need to biopsy it. So if it looks like a duck, it's usually a duck, and the same holds for liver cancers. But the decision of whether or not we to biopsy one of these growths is really dependent on the size of it. Again, if it's really small, sometimes we choose not to biopsy it. And the imaging appearance. On these CAT scans and MRIs that we do, we like to see certain features that make us pretty convinced that these growths are liver cancers. So if we see those features, that makes us, again, more inclined to think that it's most likely a liver cancer. But if some of those features are absent, sometimes we're not quite as sure. And if we're not quite as sure, and some of those features that we're looking for are not present, then yes, we will do a liver biopsy to try to decide yes or no. Is this liver cancer or not? And again, the presence or absence of some of the features we talked about at the beginning helps us decide if we should do a biopsy or not. So if there's a patient with cirrhosis, with features that we think are going to lead them to be in a high-risk category for liver cancer, again, we might not do a biopsy. But if you're seeing a growth or something that looks like a liver cancer in a patient without cirrhosis, most of the time we are going to do a biopsy. And then we have to weigh the risks of the biopsy versus the benefits. And the risks of biopsies include bleeding. If we hit a big bile duct or the gallbladder, God forbid, there could be a leak of bile from a biopsy. We can puncture different organs in the area that we're not trying to, such as the lung. And sometimes there's a risk of spreading a tumor along the tract where the needle goes. And we're trying to avoid all those things, obviously, and those risks are thankfully very low. But that's to say that if we don't feel that we need to do a biopsy because there's risk, we'd prefer not to. But if we feel that we need to, or there's some question in the diagnosis, then we will. Last slide on why did this happen. This is a very complicated, very busy slide, which I'll go through briefly, but the whole purpose of this slide is to kind of show some of the genetic mutations that occur. So on the left, you'll see the risk factors that we've gone over, which lead to chronic inflammation of the liver. We talked about cirrhosis and the generation of nodules in the liver. Different things then start to happen in the cells themselves, and some of the cells will start to undergo different genetic mutations and rearrangements, which are listed on this slide, which I won't go through in any detail. But again, the purpose of the slide is to just show that lots of different genetic variations and mutations can occur in the cells themselves, which start to predispose people to tumor growth and unopposed cell growth, which is what leads to tumors. So that's sort of the why of why it happens. So how do we deal with it? Again, these are things I'm briefly going to allude to, which we'll get into much more in the upcoming lectures. But the first thing that we like to do when we find one of these tumors is figure out the staging, which is to figure out if the tumor is isolated to the liver in just that spot where we're seeing the tumor, or has it spread anywhere else. Thankfully, these tumors are very typically slow growing. They don't tend to grow quickly or spread very quickly. Again, that's another very common question I get. In patients with these tumors, they get very worried about metastases or spread of these tumors outside of the liver. But thankfully, they're slow growing. The majority of the time, it remains isolated in the liver. But unfortunately, they can spread. They can spread into lymph nodes. We talked about they can grow into surrounding vascular structures and some of the other organs around the liver and outside the liver. So unfortunately, that becomes more complicated and difficult to treat when it happens. But thankfully, again, particularly if you're enrolled in a surveillance protocol with your doctor, the goal is to find them early and when they're isolated, still just in the liver and small. So what are the treatment options when we do find it? Surgical resection is sometimes an option that mostly in patients who don't have cirrhosis or who have very early or compensated cirrhosis. Again, we'll talk about that more in the upcoming lectures. Liver transplantation is an option that tends to be, there are strict criteria for people with these tumors who are possible enrollees in a liver transplant program and may be a recipient of a liver transplantation. That really depends on the number of tumors as well as the size of the tumors when you find them. Other treatment options include what we call local regional therapies or ablation of tumors with things such as radio frequency ablation or microwave ablation or a chemical ablation of the tumors. We can do what's called transarterial embolization of tumors, either with chemotherapy or radiation. We can do different radiation modalities such as more traditional external beam radiation. And then there's other systemic chemotherapies and immunotherapies, which are now available, again, which we'll be, I think, talking about a little bit more coming up. And then I think this is the last slide. So how do we deal with it? Again, in the center, you'll see this schematic for a patient with liver cancer or what we call hepatocellular carcinoma. And in my mind, the best treatment for this is with a big team and a team of lots of people who are working together and invested in the patient with one of these tumors. And they include your gastroenterologist and liver doctor or hepatologist, along with the radiologist who is going to help not only with the imaging and diagnosis, but also some of these interventions. The liver transplant program or surgeon who we may and very frequently include in these discussions. A medical oncologist and the pathologist who might be looking at the slides or giving chemotherapy. We're always including your the primary care doctor. And then sometimes as this tumor might become a little bit more advanced or aggressive or life-threatening, sometimes we need to involve palliative care and hospice services. And for the patients, there's always liver and cancer support groups which are available. So all of that together makes a big team. Again, in my opinion, having a team approach and all these doctors and support groups and nurses and team members working together and social workers working together closely to help the patient is what drives the best outcomes. So that's the final slide. I want to thank everyone for having me and inviting me to give this lecture. It's been an honor and a pleasure. Particularly all the folks at the American Liver Foundation who work so hard to support patients with different liver diseases. Again, thank you. Thank you kindly, and thanks for your time. Have a nice day. And please. Hello.
Thank you, Dr. Newton, for our first important presentation. As we move on to our next speaker, please make sure to add your questions for Dr. Newton in your chat feature. He will address them at the end of the presentations. Our next speaker is Dr. Scott Ellisoffen from Boston Children's Hospital. Dr. Ellisoffen is an attending physician for the Division of Gastroenterology, Hepatology, and Nutrition, the Associate Director for the Center for Childhood Liver Disease, and the Medical Director of the Liver Transplant Program. He attended medical school at Tufts University School of Medicine and completed his residency at Children's Memorial Hospital in Chicago. Dr. Ellisoffen will be speaking on pediatric liver tumors, malignant and benign. Welcome, Dr. Ellisoffen.
Good afternoon. Thanks for allowing me to speak today regarding pediatric liver tumors, both malignant and benign. My name is Scott Ellisoffen. I'm the medical director of the liver transplant program at Boston Children's Hospital. I have no financial disclosures to make today, but I do have one disclosure to make, in that kids are not little adults and they should be treated and cared for differently. And that's why I've got these 20 minutes to talk to you today. I'd like to talk a little background with you, some radiology imaging possibilities, discuss malignant liver lesions, including hepatoblastoma and hepatocellular carcinoma, as well as benign liver lesions that we will go into in some depth. Frequently, liver masses present as asymptomatic palpable masses. A pediatrician will feel it on exam, the child will have a large liver, and will lead to further testing. It also can be found by incidental findings on other abdominal imaging for other reasons, including abdominal pain. Of large masses that are seen, 2/3 of these are malignant. However, there are many other lesions that are seen in pediatrics that are not malignant, and we'll go into those in depth. How do we characterize these lesions? Radiology is usually necessary to do this, and we can look at the size of the mass. Is there one or multiple? Is it solid? Is it fluid-filled to think it's a cyst? Does it appear to be part of the bile duct system? We'll discuss this a little bit later. And how do we gather more information? Radiology is usually our answer, but sometimes we need to move to biopsy to determine what this is. Radiology tests in pediatrics are several-fold, and we have to take age and size into consideration. Fortunately, we usually start with ultrasound, which is an easy, non-invasive method. It usually works well because children are thin, and you can get very good pictures, and you can see shadowing here of the liver demonstrating pictures on ultrasound. Next are CAT scans. They have better imaging. They're fast, can take anywhere between 3 to 5 minutes to do them, so it's very short, but radiation exposure is high when you're looking using CAT scan, and you can see here's a liver mass that we see here. MRI is another trick that we have. It gives us great pictures. It has no radiation at all, and can frequently, with certain stains and contrast agents that we have now with MRI, can frequently figure out whether something looks malignant or benign, which is terrific. The problem is that you need to be still for about 45 minutes. And I don't know if any of you have kids, but usually to stay still in a thin tube for 45 minutes is extremely difficult. Therefore, MRI needs sedation. And so those are some of the trade-offs that we have in pediatrics. In terms of pediatric malignancies, leukemia and lymphoma are really the majority of cancers in pediatrics, and liver tumors, as you can see, only account for about 1 to 2% of all pediatric malignancies. By far and away, the most common malignancy is called hepatoblastoma, and this is the most common hepatic tumor in pediatrics. It's still extremely rare, 1.5 per 1 million. It almost always occurs in patients less than 5 years of age, with a mean age of about 16 to 19 months. It's more common in males than females, and the incidence has increased over the decades, which is a very interesting fact. Higher risk, very interestingly, are in children born prematurely, and especially those babies born very low, between 1,500 grams to 2,500 grams, have a higher risk of hepatoblastoma. And it also can occur with other genetic syndromes. This happens in about 20% of the cases. The first one is something called familial adenomatous polyposis. Sometimes the adults have heard of this. It's a colon polyp and cancer genetic condition, and hepatoblastoma can occur with this condition. Secondly is a condition called Beckwith-Wiedemann syndrome. It's a specific syndrome with one side of the body is larger than the other side of the body. Usually patients have a large tongue, and these patients frequently can get hepatoblastoma. When you look at the table to your right, you can see that hepatoblastoma is definitely the biggest range here, less than 5. There are small groups between 5 and 9 and 10 to 14, but it is quite small. So how does it present? Usually with an abdominal mass. It could be painful or painless. This is a CAT scan picture of a large tumor here in the right lobe of the liver. Some patients have weight loss and poor appetite. If the tumor is right near the capsule of the liver, you can have a rupture or hemorrhage into the abdomen. And many of these patients are anemic and they have elevated platelet counts indicating there's inflammation. Now, the one best blood test for hepatoblastoma is a tumor marker called alpha-fetoprotein. This can usually be extremely elevated, sometimes in the million range, and this is almost classic for hepatoblastoma. Now, how do we stage hepatoblastoma? And it's quite important to look into this. The most common way that people think about this, and I'm going to show you on the side here, is something called pretext or post-text. So pre-treatment extent of disease and how many lobes and how many areas of the liver are involved by tumor. We also want to know the post-treatment the exact same way. So if you divide the liver into 4 segments, To be able to completely resect the liver masses, you need to have at least one segment that is not accessible with tumor. So you can see here, anything 3 and above probably could be resected, whereas 4, stage 4 here, usually needs further operations, including transplantation. So we'll discuss that in a minute. Treatment is usually a combination of chemotherapy followed by surgery. And to completely cure hepatoblastoma, although chemotherapy is great, you need surgical resection of the tumor for cure. About 25 to 30% of tumors are actually able to be removed at time of diagnosis. But fortunately, in combination with chemotherapy, frequently these tumors can shrink, and then about 75 to 80% can be surgically removed well to help with cure for these patients. However, about 20% of these patients never can be completely resected, and those patients need liver transplantation, which is curative with excellent outcomes, similar to those of other liver conditions. In the United States, this averages about 45 to 60 liver transplants per year in the pediatric population for hepatoblastoma. Now, because timing of transplantation is so important in these cancer patients, they need to receive chemotherapy before transplant. They sometimes need to receive chemotherapy after transplant. It is strongly suggested to refer these patients to transplant centers early after diagnosis to determine the next best steps of care and whether they need to be transplanted. The second tumor, which you will discuss a lot with the adults, is hepatocellular carcinoma. As you look on the table on the right, this really happens more in adolescents and really very small amounts in the younger children. It's the most common liver malignancy in adolescents. The majority, though, without any liver disease or cirrhosis, unlike the adults who almost all of them have cirrhosis, which then leads to HCC or hepatocellular carcinoma. Of those with risk factors for HCC in pediatrics, there is cirrhosis, and a small percentage of children with cirrhosis will develop HCC. But other conditions are specific metabolic and genetic diseases. One is called progressive familial intrahepatic cholestasis type 2. These patients have a very high propensity to develop hepatocellular carcinoma. Same with a condition called tyrosinemia, and another one called glycogen storage disease. These patients do not have cirrhosis, but they do develop HCC. And finally, hepatitis B, not as much in the United States, but in definitely other countries, especially in Asia, and are at higher risk of developing hepatocellular carcinoma from the hepatitis B infection, which is carcinogenic. How do we treat this? It's very similar to adults, and they're going to go into this a lot more detail. There's resection with surgery. It's usually possible when a patient doesn't have cirrhosis. You can take part of the liver out and you can do okay because the rest of the liver works okay. However, if a patient has cirrhosis, they can't tolerate half of their liver or a quarter of their liver being removed, and therefore these patients usually cannot get a resection. There's also interventional radiology medications, which the adults will talk about later in this talk, so I'm going to skip that. And then transplantation, which can be curative in both the pediatric and adult literature. We have this special criteria that we use to list patients, and it's called the Milan criteria. And patients are usually good transplant candidates if they have one mass between 2 and 5 centimeters, so this picture here and this picture here, and 2 to 3 lesions with none of them being bigger than 3 centimeters. These patients can all be transplanted safely. Now, because sometimes your MELD or PELD score on the transplant list is not very high, these patients get a higher priority score immediately to move up the list so they can get transplanted in a timely manner. And unlike adults, pediatric patients do not need to wait 6 months prior to moving higher on the list. Now, what about HCC? You'll hear, quote, outside Milan criteria. So this means, and I'm going to show you in the figure here, and where it says T3 and T4, these are other size tumors or larger tumors that may be 5 centimeters or greater. Now, this is where I'll argue that kids are not little adults. And there are several studies over the last 10 years in pediatrics that although a liver tumor may be outside Milan criteria, not as much multifocal HCC, but a larger one tumor HCC, that patients frequently have excellent survival and they do quite well. And these are usually the patients that have spontaneous or HCC, meaning they have no cirrhosis, no liver disease, no genetic conditions, and they just develop HCC. And so those patients, we definitely need to consider transplantation. Now let's go into benign liver masses. This is probably the most common thing we'll see in pediatrics is a hepatic calcification. And you can see in ultrasound here, you see a nice little white dot with a shadow. It almost looks like a gallstone, but it's inside the liver. And these are calcifications. And they're usually an intrauterine vascular event that leads to a little calcified lesion. It can be from congenital infections, including CMV or toxoplasmosis, and it can be part of a larger liver tumor, which is extremely rare. This can be seen prenatally or after delivery. And fortunately, you almost never need follow-up unless it's irregular or multiple. So if patients see this, especially in little pediatric and little infants, we rarely are of concern. Hepatic cysts, you can be seen in pediatrics and adults, and these can be solid or multiple fluid-filled collections. And you can see here is an ultrasound of a nice little walled fluid collection. It's usually dark on ultrasound, as well as here's a CAT scan. So this is like basically fluid that's similar to water, and it looks nice and fluid-filled, different from the rest of the liver parenchyma. These are almost always benign and asymptomatic. 5% of the general population has cysts. For some reason, they're more common in the right lobe than the left lobe. And more importantly, they do not communicate with the bile duct system. They're almost always diagnosed by ultrasound, at least in the pediatric population. But if we are concerned that it is related to the bile duct tree, we may do more imaging. These sometimes need to be assessed and followed with ultrasounds just to see if anything is getting bigger, but usually these are completely asymptomatic. Other, quote, cystic lesions, I'll call it, because if you look at this image, it looks very similar. This looks very similar to a cyst that would be as just a regular fluid-filled cyst. However, this is a scan of a patient who has bile duct cysts. So these are actually part of the bile ducts that are becoming extremely large and cystic. So we sometimes need to evaluate whether these cysts are part of the liver or part of the bile ducts. And these can be in different conditions that are best assessed by nuclear medicine tests, MRIs, which this patient has. There's a condition called Caroli syndrome, which has very dilated bile ducts, and we see this in the pediatric population. These other two, coledochal cysts or polycystic liver disease, also look like regular cysts, but they are part of the biliary system. One of the final pictures I like to show are focal fatty sparing or focal fatty infiltration. And people may see this on their ultrasound reports, and we see this frequently in adolescents, so I wanted to describe it. So focal fatty sparing is when a patient has a diffusely fatty liver, whether they're overweight, have central obesity, for whatever reason, they have central fatty, lots of fat in their liver, but there is a benign area which has no fat. So the arrow is pointing to this right here. This actually looks like a liver mass, but it actually is just an area where there's no fat, so it looks like a mass. Similarly, we can have the exact opposite, is we have a normal liver with a fat spot, and this is right here as well, followed by the arrow here, where we call this focal fatty infiltration because the rest of the liver is normal, but we see fat that's sitting here infiltrating the liver. These are benign. There's really nothing to do about them, and we see these frequently in the adolescents. Now, it's extremely important that these do not get biopsied and really further intervene. So we like to see these patients regularly to make sure things are okay and that they are moving along. Finally, focal nodular hyperplasia. This is really the most second common liver mass in pediatrics, and it's very common in adolescents more than younger children as well. And this is a congenital vascular lesion that's suggested by a central scar that's on imaging, which I'll discuss in a minute. In pediatrics, it's associated frequently with other vascular malformations, including hemangiomas, and it can frequently be present in patients treated for other malignancies earlier in childhood. So we have patients who are treated for leukemia, lymphoma, have had bone marrow transplants, and we see them in serial follow-ups that frequently these patients can have multiple focal nodular hyperplasias. Fortunately, these do not have malignant potential, and so usually they just need follow-up. They do not need biopsies, and they most commonly do not cause any pain or symptoms. It's just they're found on part of routine imaging for surveillance, especially for these complicated patients who have had underlying procedures. This is an MRI, which shown in several different methods of looking at it, where you see really a beautiful, nice outline to this mass with a nice scar right in the middle. And this is other weights in terms of how they look at it on MRI. And you can again see this is nice here, looks mostly like liver tissue, and this white here is a nice central scar. This also is another probably FNH that a patient can have, so you can definitely have more than one of these, but this is definitely a classic finding. And when we do an MRI and see this, we really don't go any further. We don't need a biopsy. We just usually follow them for interval growth. And the only reason to remove them is if they're causing significant discomfort, which again is a very small percentage. So in summary, 2/3 of the large masses in the liver in the pediatric population are malignant. And these are things that need to be recognized. And that's why a physical exam is still so important in the pediatric population. Fortunately, liver masses make up a very small percentage of pediatric malignancies, much less than some of the other conditions. It is much, much more common to find congenital or acquired benign lesions of the liver, and that's why I wanted to go and describe these to you today. The first one being the FNH, or the focal nodular hyperplasia, which we're seeing more and more, I feel like, with more imaging done for patients. Cysts in the liver, hepatic cysts, or cysts of the bile ducts, which can also be determined by specific imaging. Calcifications, which frequently come in the neonatal period, and we need to work those up and then decide whether they need further evaluation. And then the other fatty infiltrations, called either the focal fatty sparing or the fatty infiltration, that can confuse people to think that there may be a malignancy or a mass, and really it's just fooling the eye because of sparing or infiltration. And I think the other take-home point is that patients, again, kids are not little adults. And so that if they do see liver masses, they should be evaluated by pediatric specialists, whether that's pediatric liver specialists, pediatric radiologists, to determine the next steps and to avoid excessive radiation, excessive studies, but also to get to the best answers and what's most common in the pediatric population so that we can take care of children the best and really make sure we're not over-treating these patients. With that, I think I will end and I will take any questions. Thank you.
Thank you, Dr. Elizoffen. For those who are interested in pediatric liver disease, please add your questions to the chat box. Dr. Elizoffen will be here to answer your questions at the end of the program. Our third speaker is Dr. Hesham Malik from UMass Memorial Medical Center, who specializes in diagnostic, vascular, and interventional radiology. He's also an assistant professor at the University of Massachusetts Medical School. Dr. Malik completed his medical education at Case Western Reserve University School of Medicine in Cleveland, Ohio, and his residency at Brigham and Women's Hospital here in Boston. Please join me in welcoming Dr. Malik, who will speak this evening on therapeutic options for liver cancer and interventional oncology.
Hello, everyone, and thank you for the opportunity to participate in this meeting. My name is Hesham Malik. I am an interventional radiologist at UMass Medical Center, And what I'd like to spend a few minutes discussing with you are the options that we can offer for those with liver cancer as it relates to interventional oncology. Some of you may be asking yourself what interventional radiologists do or what interventional oncology is. The way I would like to describe it is that we are physicians who have an expertise in the understanding of imaging, so CT scans, MRIs, ultrasound, and then using them to direct minimally invasive therapies, using this truly transformative technology to guide precise therapy, specifically here for liver cancer, all without you having to undergo a major incision. So it's truly a privileged position. And with that privilege comes a responsibility for us to participate in a multidisciplinary approach to offering the best possible care so that we can get you effective therapy. So the two main things that we deal with as it relates to liver cancer in terms of interventions are ablation and embolization. And by the time we discuss these options with you, you have already discussed what the nature of the tumor is in the liver in terms of number, location, and whatnot, and whether or not therapies like the ones I've described are the appropriate therapies. So ablation refers to the deposition of high energy, usually in the context of liver cancer. This is heat into a tumor. And the intention is to destroy the tumor and a little bit of normal margin of liver so that we are more certain of the accuracy of the treatment. Embolization itself is a term that refers to stopping the flow of blood to a particular region or organ. And in this context, it's the targeted delivery of chemotherapy or even radiation therapy to distribute the therapy within the site of the tumor itself and cause minimum collateral damage to the normal liver that surrounds the tumor. As a pictorial, this is a picture, a simple diagrammatic picture of the liver containing a tumor, in this case on the right side of the liver. Liver cancers are truly complex. So while we tend to think of them as tumors that derive their nutrition from the portal vein or the hepatic artery, it's quite complex, and we have a lot more to understand about this, but have developed site-specific therapies that have allowed us to control tumor. Discussing thermal ablation in more detail, that some of the terms that may be used when you see somebody and with regard to treatment of liver cancer are the terms radiofrequency ablation and microwave ablation. These are terms used to describe the kind of heat-based energy that would be delivered to the tumor. The goal for both would be the same. And the things we consider while determining how to deliver this energy are the number of tumors and the size of the tumors. That has a direct effect on what the goal is, whether or not we are bridging you to transplant or resection, or whether we're trying to downsize you to within those criteria. We do have to take care of a couple of things when considering procedures like this. We want to make sure that your lab work is within an acceptable range. And we want to make sure, based on the imaging, that there is a good way to get to the tumor to target it. This is a pictorial of a typical probe that is used to deliver such energy. In this case, this happens to be a microwave probe. So a couple of quick examples to demonstrate what this looks like on imaging. So this is a CT scan showing a liver with a tumor within it. This is an ultrasound showing one of these probes traversing this area of the tumor and getting ready to deposit the heat energy. And this is an ultrasound image showing what this area looks like immediately after delivering, in this case, what was microwave energy. You see this burst of brightness here, which shows the area where we essentially cooked the tumor, for lack of a better term. One of the newer advances in using the technologies that are available to us is that we can use fusion imaging. So on the right is a live image of an ultrasound showing a needle in the area denoted here by T1. As you could probably appreciate, we can't really see the tumor on this side, but if you look on the left side, this marks the site of a tumor that we're trying to target. And so here we were able to fuse a previous CT scan of this patient, and we're able to direct our needle to be more accurate in this location. And just as in the last case, on the right side of the screen, you see this burst of bright white area that shows the area where we deposited that high energy, which is in the same location as the tumor. That allows us to, again, deliver very specific targeted treatment. Moving on to embolization, there are a lot of different embolization strategies that we can use. Now, again, the way we perform this is by introducing under X-ray guidance and by injection of contrast dye. We go through either a blood vessel in your groin or on occasion through a blood vessel in your wrist. And we use X-ray guidance to specifically go to the blood vessels that target the arteries in the liver. And so you could inject beads that have no chemotherapy loaded on them. You could inject chemotherapy directly to the tumor, or inject tiny particles that have radiation spheres that can target the tumor itself. So this is an example of a typical approach to the specific targeting of chemotherapy for a tumor. The first picture on the top left shows us injecting contrast dye into the arteries of the liver. And this large dark structure here denotes the site of a tumor. To the right side of the screen, you see no further denotion of this area after we've injected the chemotherapy. The bottom on the screen shows you the therapy that we've targeted to this particular region. Looked at another way, this MRI on the left side shows what this tumor looked like before treatment, now being replaced as a dark hole on a follow-up scan that was performed. And this person went on to have a successful liver transplant. Moving on to radiation therapy. Now, the way we deliver the radiation therapy is essentially the same as we deliver the chemotherapy. In this particular case, this person had a large tumor in the left side of the liver, as well as a smaller one on the right side, which is outlined here for your convenience. This is a picture taken from the time of the procedure, showing you an outline of where the tumor is. We then performed the delivery of radiation spheres, again called radioembolization, and a follow-up CT scan in this person showed a really good response where the large tumor on the left side was essentially shrunk to almost nothing on the follow-up. It's also important, by the way, to know that even though we call it radioembolization, embolization does not have the same meaning when we talk about radiation therapy as it compares to chemo. So as I mentioned before, embolization is stopping the flow of blood. But radiation requires oxygen, which means we don't really stop the flow of blood. It's more of a targeted deposition of radiation. When we do the chemotherapy, we do want to slow down or stop the flow of blood to the tumor so that we starve of its supply. So different mechanisms of how chemotherapy and radiation works, but the way we deliver them essentially is the same. Now, what should we expect after the procedure, whether it's an ablation or a chemotherapy, internal chemotherapy, such as chemoembolization, or internal radiation, or radioembolization, also termed Y90, because that's the product that's used to administer the radiation. Now, the specific side effects will depend a lot on your baseline health, how active you are, how sick your liver is, how many treatments you're undergoing, what previous treatments you've had, and so on. But in general, for anyone who undergoes an ablation or an embolization procedure, there is a short period of time that you experience symptoms as if you're almost catching the cold or feeling like you have a cold. And this is termed post-embolization syndrome. It's self-limited. We encourage treatment of a low-grade fever if that occurs, or taking some medications for pain if that occurs after the procedure. We do believe that Y90 treatments, the radiation treatments that we deliver, tend to be better tolerated than the TACE procedures or the chemoembolization procedures that we offer. After you overcome the side effects, if you have any, we perform a baseline scan at around the 1 month or 2 month mark, depending on your previous imaging. And then you undergo serial imaging subsequently after that to ensure that there's no recurrence of disease. And with that, I thank you very much for your attention and look forward to answering any questions that you have.
Thank you, Dr. Malik. I'm sure our viewers will have many questions for you following all of our presentations. Please remember to add your questions to the chat feature. Before we move on to our fourth speaker, I want to once again take a moment to recognize our national sponsors, Terry Polo and Shari Arbach from Intercept Pharmaceutical, and our local pharmaceutical reps from ASI. Thank you again for your ongoing support of the ALF mission. Our fourth presenter is Dr. Patan Gultawach-Vichai from UMass Memorial Medical Center. We at UMass call him Dr. G. Dr. G specializes in hematology and oncology and is an assistant professor at the University of Massachusetts Medical School. Dr. G received his medical education at Rangsit University Faculty of Medicine in Thailand and did his medical residency at Roger Williams Hospital in Rhode Island. This evening, Dr. G will be speaking on systemic treatment options for liver cancer. Dr. G?
Hi, my name is Dr. Patan Gultawach-Vichai. I am an oncologist at UMass, and I also specialize treating hepatocellular carcinoma or liver cancer. Today, I'm going to talk about systemic treatment options for liver cancer. So what is systemic treatment? Systemic treatment is any medication that travels through your body in the bloodstream to fight, damage, or destroy cancer cells. It includes chemotherapy, immunotherapy, hormonal therapy, or targeted therapy. This systemic treatment can be either given by mouth, and if you give it orally, it will be absorbed through the GI tract. Then it will be travel through the circulation to any targeted site. Or we can give it intravenously as well. So in this route, you don't need the GI absorption. You can just bypass to step 3. So this medication will get inside circulation directly. So how far systemic treatment can travel? This is the real blood vessels anatomy. You can see that there are several blood vessels that supplying every single cells in our body. So systemic treatment will go everywhere. The only site that systemic treatment doesn't work well is inside the brain, because our brain is covered by a spatial membrane, and they would not let this medication get inside it. And when should we consider this systemic treatment option? When someone has advanced stage of liver cancer, and when someone is not a candidate for surgery or local regional approach. Let me give you some examples. The first one, this is a CAT scan that shows diffuse involvement of the liver cancer. This is the spleen, this is the liver. You can see that there are a lot of cancer right here, these black spots like over the place. This patient is not a candidate for surgery anymore, and nor the candidate for local regional approach. So this patient needs systemic treatment. Another example is when someone has diffuse metastatic disease in both lungs. One lung is enough, but this patient has both lungs. So you can see these are like multiple lesions in both lungs. Or if someone has any bony involvement, so these black spots, they represent bony metastatic disease. Do we have any options to treat? Yes, and right now we have a lot of options. In the past, we only have one, but now we have several. Today, I'll tell you how they work. This is, we call NCCN guidelines. So this guidelines is like a Bible for a medical oncologist. So all these agents are approved by FDA. Right now, for the first line treatment, we have 3 regimens, and we have several regimens for second line. Even we have a lot of agents, but all these agents can be further categorized into only 3 groups by how they work. The first one is tyrosine kinase inhibitors, or TKI. So they are within the red boxes like this. All these medications are given orally. They come in a pill form, and all of them are ending with nib, like sorafenib, lenvatinib, regorafenib, cabozantinib. So anything that ending with nib, we know that this is tyrosine kinase inhibitors. The next one is immunotherapy. So immunotherapy, we can only give it only intravenous route. So it's given through the IV. Under the green boxes, atezolizumab is one of them, nivolumab, and pembrolizumab. So there are 3 of them that are currently approved for hepatocellular carcinoma. The last group is called biologic agents. So this is not a chemotherapy. So it blocks the hormone or the cytokine from the cancer directly. And right now we have 2 of them that got approval for this indication. We have bevacizumab and also ramucirumab. First systemic treatment was approved back in 2007, and that medication was sorafenib. Since 2007, we did not have any new treatment options up until April 2017, when regorafenib was approved for second line. And after 2017, we have had several medications approved. Up until recently, we have a combination of immunotherapy and biologic agent, atezolizumab and Avastin. I'm gonna tell you how they work. So basically, tyrosine kinase inhibitor, this is a pill. The picture that I'm showing you right now is a cell, is a cancer cell. This is the membrane of the cancer cell. So the cancer gets growth signal from outside, and eventually the growth signal will stimulate through this membrane, and it will initiate lots of the steps we call kinase pathway. And this kinase pathway will eventually tell this cancer cell to divide themselves from 1 to 2, 2 to 4, 4 to 8, 8 to 16 cells, and so on and so forth. And in order to stop this cancer from proliferating, we can use these agents we call tyrosine kinase inhibitors to either block the receptor outside of the cell, or sometimes it blocks all these kinase pathway inside the cell. This tyrosine kinase inhibitor also block another pathway is called angiogenesis. So angiogenesis is the making of new blood vessel. Cancer needs to eat as well. In order to get bigger, it needs more blood vessels to supplying food like oxygen and nutrition. Tyrosine kinase will decrease the new blood vessel formation to the cancer. So the cancer will not get enough food, and then it will die. This is another picture just to show you that VEGF, we call vascular endothelial growth factor. This is the signal to tell the cancer to make more blood vessel. And tyrosine kinase inhibitor also blocks on this pathway as well. If you recall that there are three groups of medication, first one is tyrosine kinase inhibitor, the second one is immunotherapy, and the third one is biologic agent. So biologic agent such as Avastin or ramucirumab, they both block on this pathway, so they block this VEGF directly. This is a cartoon to show you how it works. So basically, this is a cancer. The cancer likes to secrete a lot of VEGF, so it can get more blood vessel. Once it gets more blood vessels, it will get bigger. So Avastin or ramucirumab will block these VEGF. Once the cancer do not get more new blood vessels, it will die because it doesn't have any food to eat. The next treatment is immunotherapy. This is one of the newest options that we have so far. So how does immunotherapy work? In general, our immune cells are capable of detecting cancer cells. They know that these cells don't belong to us and we should get rid of it. However, cancer can express a signal to shut off this T cell or immune cells function. Immunotherapy is a medication to block this interaction. So we can either block on the tumor side, or you can either block it on the T cell side. Once there is no interaction between tumor and T cells, so the T cells will become more active again. Once they are more active, they can detect that these cells don't belong to us, let's kill them. That's how cancer gets destroyed. How well do this medication works? I would like to talk a little bit about sorafenib. This is the first medication that got approval in 2007. So this medication was approved under this trial. It's called CHARP trial. This trial was conducted in Western countries. They randomized the patients into two groups: the patient with the active arm with taking sorafenib and placebo arm who did not receive any medication. Those patients who received active medication, they lived longer. So they lived in average of 10.7 months versus 7.9 months. This medication was also studied in the same population in Asian. It also showed overall survival benefit as well. So those patients who took this medication, the median overall survival is about 6.5 months versus 4.2 months in the placebo arm. These are all the phase 3 trials that comparing with sorafenib. So this is a CHARP trial, which is the gold standard treatment in the past. The blue, the green one representing sorafenib. You can see that sorafenib has been really good treatment options because it has been showing superiority or at least similar efficacy to most of the treatment. We haven't had any treatment options that is better than sorafenib until this year when we have a combination of immunotherapy and biologic agent. So this is the only one trial that showed superiority to sorafenib. And again, the first medication was approved in 2007, and we haven't had anything up until 2018 for the first line treatment. Lenvatinib is another tyrosine kinase inhibitor. It also comes in the pill form. This medication was studied in a non-inferiority fashion. It was compared with sorafenib head-to-head. So at the end, those patients who took lenvatinib, they seems to live a little bit longer, 13.6 months versus sorafenib at 12.3 months. However, it did not reach statistical significance. So what does it mean? It means that we can only tell that lenvatinib is not inferior to sorafenib, but we cannot say that it's better than sorafenib. This is the third regimen that has got approved by FDA, and this is the best regimen that we have right now for hepatocellular carcinoma first-line treatment. So this trial, they randomized the patient to combination of atezolizumab, which is an immunotherapy, and bevacizumab. This is an biologic agent that blocks VEGF, comparing to standard treatment patient who took sorafenib. And as you can see that those patients who received this combination treatment at the time of the cutoff time, the overall survival was not reached yet, comparing to sorafenib. So those patients who took sorafenib, their overall survival was shorter, and progression-free survival also longer in this combination group comparing to sorafenib. How about side effects? All these medications come with side effects. As you can see from the very first picture, systemic treatment goes everywhere in our body, so it can cause a lot of target reactions. For example, tyrosine kinase inhibitors. So on the left column, these are quite manageable toxicities. They are quite common, but they're not quite serious, not quite life-threatening. One of the most common side effects are fatigue, low appetite, hand-foot syndrome. You can see rash. The palms and plantar surface can start peeling. High blood pressure, weight loss, diarrhea, and pain in the abdomen. There are a few uncommon side effects, but they potentially be life-threatening conditions such as decreasing blood flow to the heart, bleeding, abnormal thyroid test. This one is not so serious, but perforations of the stomach or the intestines are quite serious. In contrast to immunotherapy, most patients who receiving immunotherapy tend to have milder side effects. But immunotherapy can also cause some of these treatment side effects similar to tyrosine kinase inhibitors. The only thing that is more unique is called autoimmune reactions, because we increase our immune cells activity. Instead of only killing cancer only, it can also causing some damage to normal organs as well. So it can cause inflammation to anywhere in your body from head to toes. It can cause inflammation in the skin, inflammation in the liver, inflammation in the kidneys. That's why before we start any immunotherapy, we're gonna have to check all the blood works, make sure that there's no sign of inflammation before we start this treatment. I already covered all the first line treatment. There are right now we have 3 approved regimens so far. For second line treatment, we have 4 options. So we have regorafenib, which is a pill. Cabozantinib is a pill as well. Ramucirumab, this is an infusion, and this medication is only approved for patients who expressing a lot of tumor marker we call AFP. So this marker tends to portend bad prognosis for patients with liver cancer. And if it's high, they tend to respond quite well with ramucirumab. And the last one is in immunotherapy, nivolumab and pembrolizumab. So these are early introduction of the systemic treatment options in hepatocellular carcinoma. If you have any further questions, I'm happy to answer them. Thank you so much for your attention and have a good night. Bye-bye.
Thank you, Dr. G. If you have any questions for Dr. G, please add them to the chat feature below. Our final speaker of the evening is Dr. Babak Movahedi from UMass Memorial Medical Center. Dr. Movahedi is a transplant surgeon and an assistant professor at University of Massachusetts Medical School. Dr. Movahedi attended the University of Brussels for medical school and his residency at Universitair Ziekenhuis in Brussels. Tonight, he will be speaking on surgical options for liver cancer. Welcome, Dr. Movahedi.
Good evening. Thanks for joining us. Tonight we'll be talking about surgical options for treatment of liver cancer. The objective of tonight's talk is to better understand the surgical possibilities to treat hepatocellular carcinoma. This will include liver resection and liver transplantation. I have no conflict of interest. To put it in an oversimplified way, the liver is built out of two main components. Those are, on one hand, liver cells or hepatocytes, and on the other hand, bile duct cells that form liver bile ducts. Liver cells are extremely sophisticated, tiny chemical factories that process thousands of different compounds. They neutralize toxins and medications, and they also produce many different proteins that our body needs to function properly. Liver cells also produce bile that helps to get rid of some of the body's waste products and helps with digestion of fat. Bile that is produced by the liver is collected in small channels that come together to form larger bile ducts and finally the common bile duct. And that common bile duct transports the bile to small bowel. Cancer can rise from both hepatocytes and bile duct cells of the liver. When it's originating from hepatocytes, we call it hepatocellular carcinoma, or abbreviated as HCC. And when the cancer is originating from bile duct cells, it is called cholangiocarcinoma. These cancers are called primary liver cancers because they are produced primarily inside the liver. Now, oftentimes you'll find cancer in the liver that originated in some other part of the body, for example, colon. Those cancers can spread to the liver and form a liver metastasis or cause a liver metastasis. These cancers are called secondary liver cancers. For the purpose of today's discussion, we'll only talk about hepatocellular carcinoma. Liver cancer can be cured if the tumor can be completely removed from the body. This can be done in two different ways. First possibility is to remove the cancer by resecting a part of the liver or removing a part of the liver. One or more parts of the liver that contain the tumor are then essentially cut away. It's important to remove the entire cancer and at least some surrounding liver tissue so that we're sure that we don't leave any cancer behind and the margins are free of cancer. The other possibility is to remove the entire liver with the cancer in it and replace it with a healthy liver from a donor. This is obviously called liver transplantation. Now, a healthy liver has ability to regenerate. In other words, when a portion of the liver is removed, the remainder of the liver will grow in size until it reaches a volume that is pretty much identical to before resection. Most of this growth happens pretty quickly within the first 3 months after resection. In a healthy liver, more than 70% of the organ can be removed if necessary. Now, the amount of the liver that safely can be removed really depends on several factors. One is the quality of the liver, but also the general health of the patient. Now, if the liver remnant or the portion that is left behind is too small, the patient can develop liver failure, which could be fatal. Although from the outside, liver appears to be a single large organ, from a functional standpoint, liver is built out of 8 independent units that are called liver segments. Each segment has its own vascular inflow, outflow, and biliary drainage. This classification of the liver anatomy is called Cugnot's classification system, that is called after French surgeon and anatomist Claude Cugnot, who published his work on liver anatomy in the 1950s. Before that, liver resection was pretty much impossible, so this was a major advancement in liver surgery. The types of liver resection and extent of liver resection depends on many different factors. These include location of the tumor or tumors, ability to provide an adequate future liver remnant, and a tumor negative margin. Liver resections are performed by staying within the realms of segmental anatomy and performing the resection in between these functional units. The types of hepatic resection include wedge resection when the tumor is very small and peripheral in the liver, right or left hepatectomy when the right lobe or left lobe of the liver is removed, and extended right or extended left hepatectomy. Although surgical resection is the preferred approach in treatment of hepatocellular carcinoma, only a small portion of the patients will be a good candidate for that surgery. And the reason is that the cirrhosis is the major risk factor for developing liver cancer. In fact, more than 90% of patients with hepatocellular carcinoma have underlying cirrhosis. Once the liver becomes cirrhotic, it loses that ability to regenerate. And a partial resection of a cirrhotic liver will often lead to liver failure. And then also that remnant cirrhotic liver, even if it doesn't fail, it continues to be at very high risk of developing new cancers in the future, because the risk factor is cirrhosis, and cirrhosis will still be there. For patients with cirrhosis who would not tolerate a liver resection, liver transplant is the only other potentially curative option. If the tumor is within certain criteria, which we'll talk about in a little bit, liver transplant can provide excellent long-term cancer-free survival for an otherwise very deadly disease. Liver transplant, however, is not the right answer for everyone with cirrhosis and liver cancer. A landmark paper from 1996 by Mazzaferro and colleagues showed that by carefully selecting patients for transplantation according to specific strict criteria, excellent disease-free survival can be achieved. These criteria are now called the Milan criteria. Patients with tumor burden that exceeds these criteria are at higher risk of tumor recurrence after transplant. Meanwhile, these criteria have been adopted by Organ Procurement and Transplantation Network, or OPTN, as a guideline for listing patients for liver transplantation. Patients are deemed within Milan criteria if they have a single tumor that is smaller than 5 centimeters, that is about 2 inches, or up to 3 tumors when none of them is larger than 3 centimeters. Additionally, tumor may not invade any large vessels of the liver, and there cannot be any evidence of cancer outside of the liver. Patients within Milan criteria who undergo liver transplantation have excellent survival outcomes. Their outcome is pretty much identical to transplant patients that get their transplant for any other indication. When these criteria are strictly applied, the Milan criteria, the 3 or 4 year survivals are up to 75 to 85%. And 80 to 90% of patients remain long-term free of any cancer recurrence. There is, however, an important caveat that we need to keep in mind. These excellent results were achieved in a time and an era when the organs were promptly available and waiting time for liver transplant were very short. More currently, as you all know, there's a huge shortage of donor organs, and there is a significant delay between the time that someone is listed for a transplant and the time that they actually receive the liver transplant. During this extended waiting time, tumor can obviously continue to grow and could progress to a point that is beyond those Milan criteria. Now, despite lack of strong data from controlled clinical trials, it is generally believed that patients with HCC that are waiting for a liver transplant and are expected to have to wait for more than 6 months, which is essentially all the patients, will benefit from local regional treatment of their tumors. This as a bridge to liver transplantation. Now, those different techniques of local regional therapies were covered earlier today, so I will not go over them here. But the general idea is that by locally treating the tumors, the progression of cancer can be slowed down or even halted until the patient can undergo a liver transplant. Additionally, these techniques are also used for downstaging. This means that patients who have a tumor that is beyond the Milan criteria, so one single more than 5 centimeters or more than 3 tumors, these cases can undergo local regional therapy to decrease the size and the number of tumors to a point that the patient is again within those Milan criteria and can receive priority listing. Now, the liver transplant allocation system in the United States is currently based on model for end-stage liver disease, or the MELD score. This system is designed to give the highest priority to patients that are the sickest, and those patients will have the highest score. MELD score is calculated based on 3 lab values, which are bilirubin, INR, or how the blood is clotting, and creatinine, which is a function for kidney, or which is better said, a marker for kidney function. MELD score ranges from 6 to 40, and it really is a marker of how severe patient's liver disease is. In patients with cirrhosis, MELD score predicts the risk of mortality or risk of dying in the next 3 months. For example, a patient with a MELD score of 6 has a very low risk of dying, only 2%. As the MELD score rises, for example, a MELD score of 20 reflects a risk of 20% mortality in the next 3 months, and a MELD score of 40 predicts a mortality risk of almost 90%. Despite several advantages that the MELD score has, some patients' severity of illness or risk of complications are not accurately reflected by the MELD score. For this reason, there is a system of exception points in place. Those are called MELD exception points. Those exception points are given to patients with certain conditions that are waiting on the UNOS transplant waiting list to give them opportunity to receive a liver transplant in a timely fashion. Patients with hepatocellular carcinoma can receive priority MELD points if their HCC is at stage 2. And their serum level of alpha-fetoprotein is less than 1,000. Alpha-fetoprotein is a protein that can be produced by the HCC, by hepatocellular carcinoma. Not every HCC produces alpha-fetoprotein, but if alpha-fetoprotein is more than 1,000, it's typically a marker of very aggressive tumor biology. Now, to assess the stage of HCC and to qualify for exception points, patients must undergo a thorough assessment of their HCC. We need to know how many cancers they have and what the size of those cancers are, and also to rule out extrahepatic spread and or involvement of blood vessels of the liver. This evaluation can be done through a CT scan or MRI of the abdomen, as well as a CT scan of the chest and a blood draw to measure alpha-fetoprotein level. Even if the patient is within Milan criteria, UNOS requires a mandatory 6 months waiting period before those exception points are granted. The way exception points have been granted for HCC patients has changed many, many times over the past several years. Right now, those exception points are calculated by subtracting 3 points from median MELD at transplant. Now, what is median MELD at transplant? That is the median score at which patients get their transplant in a certain area. And that score is calculated every 6 months. For example, for us in central Massachusetts, the current median MELD at transplant score is 31. So then all patients with hepatocellular carcinoma that are within Milan criteria receive 31 minus 3, so 28 points, and they stay at that 28 points until they get their transplant. Living donor liver transplantation provides opportunity to avoid extended waiting periods for deceased donor liver. This is a significant benefit in patients with HCC because the tumor growth during that waiting period can worsen the prognosis. Even with bridging therapies, patient can fall outside of Milan criteria. Unfortunately, only 5% of all liver transplants in the United States are done with living donors, as compared to almost all the transplants in Asian countries are from a living donor. Now, in addition to shortening the waiting time and decreasing the dropouts because of tumor progression, living donor transplant can also provide access to liver transplant for patients who are otherwise outside of the Milan criteria and would not qualify for listing for a deceased donor liver transplant. To summarize, I think we said that hepatocellular carcinoma is potentially curable through complete surgical removal of the cancer, either by liver resection or by liver transplant. Although hepatectomy is the preferred approach, majority of the patients with HCC have underlying chronic liver disease and are not a candidate for liver resection. For patients with cirrhosis and HCC between Milan criteria, liver transplant is a treatment of choice with excellent long-term outcomes. Local regional treatments are a good bridge to transplant. Patients that qualify will receive exception MEL points to improve their chances of a timely transplant. And finally, living donor liver transplant can shorten the waiting time and improve the survival chances and offer potential cure for tumors beyond Milan criteria. Thank you very much for your attention.
Can everyone hear?
Can you hear me?
Sorry, can everybody hear? Okay, great.
Yes.
Great presentations. Hello, everyone. I'm Tom Seepy. I think we're going to have some fun now and try to spend some time going over some questions from the audience.
I think someone asked a question for Dr. Newton on the chat box.
Yeah, I think that one came from Tricia Lapointe, who's a pharmacist. It looks like her question to you, Dr. Newton, is were there any insights or thoughts on the use of aliglitazar and eltrombopag?
So that's a great question. Thank you. I think everyone on the panel might have a different feeling about the use of some of those medications. I know which are meant to boost platelets. And there's different times and indications for which you can do that. For invasive procedures, there are certainly times when the platelet count is extremely low that we may choose to want to do that. It's not something I've had a tremendous amount of experience using, and I'd be curious to know what the rest of the panel has to say about their experience with it. I think it can be helpful when the platelet count is quite low. A lot of the procedures that we sometimes will need to do, whether they're biopsies or endoscopies with banding of varices or paracentesis or some of the interventional procedures that the radiologist spoke about, it's helpful to have the platelet count above at least 50,000. So at times, if the platelet count's below that, certain drugs can boost that level. So I'll defer to the rest of the panel and see what other people have to say about it. But in the right setting for the right procedure, when the platelet counts are very suppressed, it can be very helpful.
Yeah, I'm going to agree with everything that you said on that one. I think that the experience that I've had has been a little bit hit or miss. I think you and I actually have a patient together who is about to have a live donor liver transplant, and we were able to boost her platelets up from about 42,000 up to about 100,000. But I think in other patients, I've used things like eltrombopag and haven't really noticed any big difference. And then in other patients, there have been risks associated with clotting or kind of overdoing it with that clotting cascade when it comes to platelets.
Actually, if I could just amplify on that, because I really have not used the medication. Maybe I'm just old school and we always grew up doing banding and a lot of invasive things with borderline platelet counts and people with advanced disease. But from our surgical colleagues, does it make a difference? Because if you're dealing with someone with very advanced liver disease, platelet counts of probably 60,000 at baseline, uh, does it make a difference to have that platelet count at 100,000 before embarking on transplantation or not? I'm just kind of curious. I don't know if our transplant surgeon is on the call at this point.
Yeah, that's a very good question, and the answer is absolutely not. You know, whether the platelet count is 20,000, 80,000, 120,000, whether patients are on Plavix and aspirin or not, liver transplant is a bloody procedure, no
Right.
matter how you look at it. And it's really not only a matter of production, but also a matter of consumption in people with portal hypertension. There is a huge pooling of blood in the spleen, which causes the platelets to be consumed more than normal. And you can give those patients several units of platelets, and if you measure it 6 hours later, it's all gone because it really they get consumed. So we do use platelets during transplant, but that is really at the very end. Once the liver is in place, the portal hypertension is addressed, and there is this ongoing oozing from all the raw surfaces and all the surgical areas, giving additional platelets from donors does help to slow down the bleeding. The only times that we use platelet boosting medications is in patients who, after transplant, usually because of drug reactions, a lot of drugs have suppressing effect on platelet counts, and their platelets drops to, scary low numbers, under 10, which really puts them at risk of intracranial hemorrhage and strokes and things like that. In those patients, we have been using those medications, and to some extent, not in every single patient, but we have had good results with some of those.
Yeah, I think the other part of the question was about aldaglipizar, which is I think an investigational drug to slow cirrhosis, and it's not something I'm particularly familiar with or have a lot of experience with. I think it's still something in the clinical trial space, and I'll punt that to my good friend and colleague Dr. Sepe if he's had any exposure or usage of it in his clinical trial arena and space.
I don't have any particular experience with that agent. I think there are really many drugs now that are being tested and under development to reverse fibrosis. I think they're fascinating. I think they're probably useful for people who have advanced fibrosis or early cirrhosis. I think when we're getting, closer to the point of dealing with the questions of liver transplantation or people who develop hepatoma, I'm not sure what the role is going to be in those patients. I think right now the FDA has actually been really pushing us to try to look at a lot of these investigational agents in mid-range fibrosis, and we're saving, careful study of cirrhotics until we get a better safety profile in larger numbers of patients. So I think stay tuned. I think if we do this program in another year or 2 or 3, we may have more insight. But at this point now, that's the beauty of clinical research, which unfortunately with COVID has been quite delayed in the last 6 to 9 months, but we're getting ready to start boosting up again. I have a question for we have great colleagues here, really, people are in the front lines doing all types of therapy. We're confronted with hepatoma all the time. What are we thinking about? When I see someone with a hepatocellular carcinoma, if it's isolated, I spend most of my time trying to figure out how best can we cure the patient. There are some patients, though, it's always been argued, if they have a small peripheral lesion, should it just be resected with all the problems of getting them transplanted? So I want to get, because we have great experience from the hepatologist, Babak. I want to get your feeling like, when do you wedge out a small hepatoma and wait to go down the pathway of transplantation, which has always been my bias. I really try to exhaust that and have whoever I refer my patient to for that question tell me that they're not a transplant candidate or they are. So I think that's a fun one to try to, I know it's been dealt with in the lectures, but in a lecture format, might be fun to get people to interact on that question.
Isabel, you want to go for it, or do?
Oh no, you go ahead.
Sure.
It's an easy question, right?
Yeah, I mean, I guess part of it is philosophy, and part of it is data. I mean, the first question you really need to ask is this HCC in a background of otherwise healthy liver, and is an isolated tumor that pops up. And if you resect it, the rest of that liver is maybe at a relatively low risk of developing new cancers, because it is not a cirrhotic liver. Even if a child is cirrhotic liver, that's a very fertile ground for developing new cancers. As you know, cirrhotics have 20 times higher risk of developing HCC. So you take one out, and then 2 years later, there is another one. And, just doing that partial hepatectomy makes the future transplant much more risky operation, because of, someone having been there and resected and all the adhesions and everything that develops. I mean, if the patient otherwise, let's say a hepatitis B patient with no cirrhosis, by all means, I think if you can resect it, you should go ahead and resect it. However, that's only a very small number of patients that fall in that category. A majority of patients with HCC have underlying cirrhosis, and even if it's a early cirrhosis, and you could potentially resect it and get away with it without causing failure and all of that, the question is, should you do that? Because the chances of getting new primaries in the future. Obviously, it's not always black and white, and you really need to put the risk of lifelong immunosuppression and a transplanted liver, risk of infection, and increased risk of other cancers like skin cancer and all of that come with immunosuppression, as opposed to risk of that HCC alone. And that's where it becomes more, philosophic, and some programs are more aggressive towards transplant, others are more aggressive towards resection. I think our program is a little bit leaning more towards transplant because of all the things that I just mentioned. But I don't think there is an absolute truth there, and both ways could be justifiable.
Good. Great answer. I have two quick follow-ups. I don't want to dominate this, but this is fascinating. Does age factor in? So if you have, a 50-year-old who has cirrhosis with an isolated lesion, we probably want to transplant that patient because the chance of having a recurrent tumor would be much higher. But if you have a very healthy 76-year-old, would that factor in? That's very healthy. I mean, we do have some healthy 76-year-old patients out there. Do you ever consider age in that spectrum in your decision making?
Well, absolutely. As the age goes up, also go the risk of a potential transplant, and it's not a small surgery. Just right. Getting the patient through the surgery, and the time that the patient has to develop new cancers. If you're 50 and you anticipate to become 80, you have 30 years for that liver to make new cancers. Where if you're 76 and you anticipate to become 80, you have only 4 years to get away. And you could even wonder in those patients whether something like local regional treatments would be, if it's resectable and the patient would tolerate it, that is absolutely the most curative way. But if you have a patient that's really not in good shape and you're trying to buy him time, then it's maybe local regional treatment the way
Right.
to look at. So I think it's really, we talk about individualized medicine, and this is the best example that you really have to tailor it to every single individual patient.
Great. Any other feedback along those lines?
Yes, I'd like to add something, if that's okay. Hisham Malik here again, one of the interventional radiologists on the panel. Along with what Dr. Muvahedi said, the advances in the delivery of local regional therapies, specifically Y90 radioembolization, really allow us to introduce or reintroduce the concept of the biologic test of time. So if you're uncertain whether a patient is a good candidate for resection, or if you're working them up for resection, and you're thinking it's either going to be a wedge resection or a right hepatectomy, there are techniques that we have now developed in the delivery of targeted radioembolization that really allow us to not only control the tumor, in many cases achieve similar results to resection as it relates to recurrence rates and so on, and also understand the development of the tumor as it relates to tumor biology. So such advances really help us, as Dr. Muvahedi said, to tailor these therapies and still consider either resection or transplantation, depending on how the patient fits into that decision-making tree.
Excellent. Any other feedback on that line?
Us in the pediatric realm, we're in a whole different group here, but I would say the majority of our patients do not have underlying cirrhosis. And so I think we try to go for resection if possible, unless it's a multifocal lesion.
That's great. Excellent.
So I just wanted to ask a question also to Dr. Malik. That you mentioned the variety of different techniques like ablation, embolization, and Y90. Are there times where you would consider doing just a single therapy versus combined modality?
That's a difficult question to answer, because the challenge here is whether or not you approach it from a purely scientific perspective, or your bias as to which way of delivering therapy you think will give you the best response. So one way of looking at it is how the tissue looks under pathology when we try to learn these things from folks who've undergone resection or liver transplant and see which therapy results in the best response in pathology. One of the things that is very good and unfortunate at the same time with imaging is that though we use imaging to detect cancer, imaging is not perfect to tell us whether the cancer is absolutely dead after we use ablation or SBRT or TACE or whatnot. And we know that from pathology specimens that we have received after patients undergo resection or liver transplantation, that tumors that looked dead on imaging are not completely dead. In some cases, maybe only 50% dead. And that may have an effect on whether there's going to be tumor in the rest of the liver, whether the patient will develop tumor later on. So if you take all of that together, if one were to use a single modality because that's best tolerated and it's easiest to offer, my bias is towards the studies coming out on selective internal radiation therapy, which is Y90. Nonetheless, there are options that have been used for using more than one modality. And one such option is to combine chemoembolization with ablation. The whole effort is to try and get as close to 100% of the tumor cells dead. So whether you think you can achieve it with one therapy or more than one depends on, in some cases, what science you believe in more, whether the science of killing something with radiation makes more sense, or whether the science of starving something of its oxygen supply or burning it in place makes more sense. I think ultimately we may have equivalent results with some of these therapies, and so then it will be important to see there are more difficult questions to answer, which is more cost effective, which is easier to tolerate, and so on. So I think there's lots of exciting work going on there. But if you ask my bias, if I was to use one therapy, it would be Y90.
Thank you. I can ask a question to Dr. Movahed. You know, when someone goes in, just in speaking with what Dr. Malik said, is that sometimes even though, you know, you target the treatment with the variety of different techniques, and the imaging study like an MRI scan or a CAT scan suggests that there really doesn't seem to be any more viable tumor, once you do a liver transplant, that whole organ comes out and gets evaluated under the microscope. Are there certain features that put patients at risk for developing recurrent HCC or liver cancer following a liver transplant?
Yeah, absolutely. You know, we're talking about HCC as it's like one entity, and it's not. Essentially, it's a mixed bag of many different tumor biologies and degrees of aggressiveness. And there are definitely markers that we look for in that specimen to guide us how aggressive these tumors are. And to give you an example, if the tumor is invading the small lymphatic vessels or the nerve cells, so what we call it perineural and peri-lymphatic invasion, those cancer tends to be a little bit more aggressive and have somewhat higher risk of recurrence as opposed to cancers that they don't do that. And there is a lot of research effort going on to look at the genetic signature of those cancers to see if one can sort out which cancer is at high risk of coming back. And I think others can probably, give more information on that. But essentially, removing the cancer, whether it's by burning it completely or removing a portion of the liver, or removing the entire liver and doing a transplant, is the best option for the patient, even if those recurrence rates are existing. You know, with systemic treatment, we're just looking at the data. You can have 3, 4, 5 months of survival benefit. With a transplant, even if the recurrence rate is 20, 30%. In 5 years, I would call that an amazing outcome. But the reason that we don't transplant everyone is really because of shortage of organs, and so we don't have enough livers to give to everyone. Otherwise, everyone would benefit from a transplant.
This is kind of a question for everyone, but whoever wants to answer. Is the treatment for HCC in a transplanted liver different in any shape or form comparatively to your original liver in terms of considerations to be taken?
You know, that's a very good question. Usually when you have cancer in the transplanted liver, it's a recurrence, which means that the cancer was in the original liver, was floating around in the body. You put a new liver in, and that cancer goes and homes in that new liver. And, you know, when you are at that point, this is considered a generalized cancer. So if it's growing in that liver, it's probably also growing in other parts of the body, or soon will be. So when you have those cases, I think it's really the only thing that would be helpful is a general treatment, a systemic treatment with immunotherapy, chemotherapy, and that sort of It's probably not impossible to develop a primary cancer, HCC, in a transplant of the liver, but those are far and beyond the exceptions, and the majority of cancers that develop have been spreading throughout the body, and liver is a site that it can grow.
I'll ask a question to Dr. Ellisothan. You know, because you're among the minority in the group, because all of the rest of us, I think, unless the panel that's logged in, but you know, we're dealing with adult patients and, you know, tackling things like liver cancer, which is, you know, a huge deal in an adult patient. But you know, if you take it towards lesions in the liver that are cancerous for the pediatric patient, it just brings on, I think, a whole element of something very different, you know, just a lot of stress, and it's overwhelming for not only the patient, but also to the parents. How do you tackle delivering news like this to the pediatric patient and the patient's parents?
Yeah, so that's a great question. So I think, so our most common liver cancer is by far is hepatoblastoma. And as outlined in the lecture, it usually happens in the first few years of age, with the median being somewhere in the upper 1 to 2 years of age. So frequently, you know, the child really does not know what's going on. They're pretty young. They can't really understand what's happening. But you just need to sit down and discuss it with the family, and, you know, be honest as possible, just like you would with an adult patient. And I think the best part is, at least from hepatoblastoma, is that this is a very survivable cancer. There's been new chemotherapies over the last 10 to 20 years that are very successful. So some patients will have a large liver lesion, and even sometimes some lung metastases or small lesions in the lung. And then after about 1 or 2 cycles of chemotherapy, the lung lesions will dissolve. They'll go away. You couldn't even see them. If you tried to do a thoracoscopic exam, you wouldn't be able to find them. So it really responds well to chemotherapy, and really, though, you need to remove the whole tumor. So if these are unresectable or in multiple lobes of the liver, you know, then a transplant is necessary. And we, you know, really have excellent outcomes. They may be a little bit less than someone with chronic liver disease, but really excellent outcomes. And so I think it's pretty encouraging, and when we're talking to parents. Also, it's only about 20% of those liver tumors that need liver transplant, because the rest of them can be resected and cured with chemotherapy and resection. So, you know, sometimes, and our group really, you know, our oncology groups are so strong, and especially in pediatrics as well, is that sometimes we don't really get to meet some of these patients until they're referred for transplant. Sometimes they're referred directly to the oncology service. So it's a little different, I think, in that regard. We sometimes see the patients after they've done their chemotherapy and are ready for transplant, or they know they need a transplant.
And then to follow up on that question, would these patients be eligible for live donor liver transplant?
Absolutely, absolutely. And sometimes we do that because we like to time transplant around chemotherapy. So some of the most recent studies show about 6 cycles of usually cisplatin and doxorubicin treatment plans or courses. And so we usually like to give about 3 to 4 cycles before transplant, then do the transplant, and then give at least 1 or 2 cycles post-transplant, as just as the surgeons were talking about, if there's anything floating around, to really mop up anything else that's there to prevent a recurrence from happening. So we really try to time that. And fortunately, children with hepatoblastoma are put very high up on the transplant list, just below status 1A, which is acute liver failure. So these patients frequently can get a small part of an adult liver or a size matched liver in a timely manner, but we usually will have a backup ready with a parent or loved one or someone else who's going to donate, so that if we're not getting the timing we need, that we can move to a living donor. The only real living donors that do not work is if there's tumor growing really into the portal vein, which does not seem to decrease the success of the transplant, at least with hepatoblastoma, as it does with hepatocellular carcinoma. But those patients may not be able to get a living donor.
Gotcha. Thank you. And I have a question for Dr. G. When you're trying to think about which patients would benefit from something like lenvatinib versus sorafenib, is there something that you look at that would differentiate using one of the medications versus another?
Yes. So first of all, before we start any treatment, we have to see whether the patient is fit enough or not. So we look at the ECOG performance score. So if it's below 2, the patient is eligible to get some kind of treatment. Then you have to look for all those contraindications. For example, if the patient has problem with autoimmune diseases, or this is a post-transplant patient, of course, you would not pick immunotherapy upfront. So you would start with the tyrosine kinase inhibitors, such as could be sorafenib or lenvatinib. And then you can ask the patient for their preference, whether they want to get an intravenous treatment or they want an option in a pill form. If they have problem with transplantation, of course, they don't want to just come to the clinic every 3 weeks just for infusion. They prefer to stay at home taking pills, and they come to see me when they really need to. So they are so all these treatment options would be individualized based on their preference and based on all their medical underlying diseases.
Actually, I have another question for Dr. G. Maybe it's a good question to run by everyone on the panel, but right now you did a beautiful overview of all the different, standard treatments. What are you most excited about? Something on the horizon. Is it a particular form of immunotherapy? Targeted immunotherapy is very hot right now in a lot of tumors. We've always lagged behind in hepatoma. We're all thirsting for the same leaps and bounds that we might have seen in lung cancer and lymphoma and some other areas. What are you most excited about doing at the forefront of research that you think could be really a major advance in the next 12 to 24 months?
Unfortunately, there's not much breakthrough findings from oncology standpoint. Right now, the best treatment that we have is a combination of immunotherapy and biologic agent, atezolizumab and bevacizumab. So in the future, I would expect that in next few months, we will get an approval for a combination of tyrosine kinase inhibitor and also immunotherapy. So in the past, if you think about the response rate, so let's say that sorafenib, in the past, the response rate, the objective response rate is only like 5%, 6%. I always tell patients that don't hope for too much. The risk of getting the chance of that you're gonna see some shrinkage from the treatment only happen from 1 in 20 patients. But right now you can even aim for like 5% of complete response. And I have like 1 or 2 patients who got quite extensive tumor burden, and within 3 or 4 months after the standard, the systemic treatment, all those tumors just melt away, which is like unheard of. And we found that the combination between a tyrosine kinase inhibitor and immunotherapy can induce that kind of response as well. So I think it's kind of exciting because we don't have any treatment like that yet. So I think we will have a better hands-on experience in the next few months.
Thank you. Actually, I'm going to keep the question going, but to our transplant surgeon, Dr. M, what are there any techniques, or do you see any advances coming from a technological you're approaching transplantation and the liver cancer patient? Because I think with the progression of NASH and fat-related liver disease in this country, we're going to be buried with hepatoma within the next decade, and we're going to really be overrun by a lot of important treatment decisions in sick patients. So I was just curious, is there anything on your horizon on an investigational standpoint that you would like to share with the audience? Oh, I think you might be muted.
Thank you for reminding me of that. The whole concept of Milan criteria is really based on a study of 46 patients in 1996. So you can wonder how how accurate that still is today. And there has been several studies since that all have been suggesting that the Milan criteria are probably too restrictive. In other words, that there are a lot of patients that are beyond those Milan criteria, have more than 3 tumors, or the size is larger than 5 or whatever, that would benefit from a transplant equally as patients that are within Milan criteria. But right now, don't get that opportunity because we're restricting it to these. And a good example is what we call the UCSF criteria, that is more aggressive and goes beyond that. Now, it is the problem with transplant is that the bottleneck, the limiting factor, is number of available organs, and you're really trying to share those organs among people with cirrhosis, that have liver failure, high MELD score, people with hepatopulmonary syndrome, people with hepatocellular carcinoma, and everyone else that needs a transplant. And they're all trying to, you're trying to distribute this scarce resource in a just way between all of those patients that need a transplant. And I don't think it's feasible to think that suddenly the number of donors are going to go up and we're going to have more. That would be a bad thing, which means that a lot of people are dying. But however, there is an outweigh there, and that is, using of living donor liver transplant, which is an amazing resource that is totally underutilized in our country here. If we had a more aggressive living donor transplant approach or culture in the United States, many more people would be able to get a transplant and survive and cure from their, whether it's hepatocellular carcinoma or other types of liver disease, as we have now. On average, on our national liver transplant waiting list, there are anywhere between 12,000, 16,000 people waiting, and there is only a fraction of that number available in organs, maybe 5,000, 6,000 a year, which means that the majority of people end up not getting transplant. And those are only the listed patients. A lot of patients that would benefit from a transplant are not listed because we know that they are outside of the criteria that would allow them to get a transplant. So, we can't make the livers, we cannot use animal livers, so the only way to do it is with human organs. And since the number of donors have been pretty much fixed for the past many decades, so the only outway here is living donor, and we need to put more effort in advertising that and informing people so that more lives can be saved.
So I guess now is the time that I jump in. I just wanted to remind everyone that the American Liver Foundation offers a variety of liver health resources to patients, caregivers, and the general public. We give you an invitation to visit our website to learn more about liver cancer or call our national helpline for assistance. We also invite you to follow us on Facebook and YouTube. Lastly, and most importantly, a special thank you to all of our MAC physicians and our moderators, Dr. Zacharias, Johorian, and Seepi, for sharing your expertise and time with us tonight, as well as our national and local sponsors who continue with their philanthropic support of our educational program. On behalf of the American Liver Foundation, I thank you each for joining us this evening. We hope you found this evening helpful and informative. Thank you, and please stay safe. Good night.
Thank you, Sherry.
Thank you.
Good night, thank you.